Nicole. Thank you, everybody. Good evening. Thank you for being on tonight. Thanks for joining us for, I think we're at number 6, maybe 7 web series presentation on joint preservation using Escore by Subchondral Solutions. My name is Matt Tebow with 2 T's, and I am the South Central Regional Manager. And tonight we have Dr. Brian Benson coming from what I consider the motherland, which is Louisiana, out of his practice at Beauregard Foot and Ankle Associates. He'll be presenting Escore, first MPJ, and beyond. Dr. Benson is a fellowship trained podiatric surgeon, foot and ankle, specialized in advanced reconstruction of foot and ankle and lower leg, including total ankle joint replacement, external fixation, limb lengthening, minimally invasive surgery, foot and ankle trauma, orthoplastic techniques, arthroscopic cartilage repair, diabetic limb salvage, and complex deformity corrections. Dr. Benson has about 2 years of experience in data using Escore in the first MPGA and well beyond, as I said, including the lesser MES and Talus. We're trying to keep our best to keep these presentations around 25 to 30 minutes. And there's the comments I'll start popping in on there for any questions that you have during the presentation. So hopefully if we can finish, within about 30 minutes, we'll take some Q&A. We've got plenty of time, but we want everybody to be able to get back to their families. So without further ado, I'll turn this over to Dr. Benson.
All right. Well,
I think you should be able to take over the screen here.
All right. So let me go ahead and do a screen share. There we go. Can everybody hear me?
I know I hear you.
Yep.
All right, good. So,
looking good.
First of all, thank you, Matt. I really appreciate it, and everyone that's on the call from Subchondral Solutions. I really appreciate you guys, setting this up. Of course, it was scheduled to go about a month and some change ago. Had something come up, so we had to reschedule. So I apologize, but I really appreciate everyone coming on tonight and the support from Subchondral Solutions. As Matt said, my name is Brian Benson. I currently practice in DeRidder, Louisiana. And the easiest way to explain that is if you know where Lake Charles is, just get on the highway and go north, but try not to blink, because if you do, you might miss it. But it is a great area to live in, great area to practice in. Primarily as a hospital employee, I see, of course, a lot of diabetic limbs. I see a lot of revisions and a pretty good mix, of osteochondral defects. A little bit of everything comes my way. And of course, Subchondral Solutions, the Escore, was introduced to me a little less than 2 years ago. And of course, as you guys are very familiar with, every time there's a new product, they a company will say it's the best to address a particular pathology. And of course, my own skepticism inherently as a surgeon always kicks in. But as we go through this presentation and move about, you will begin to hopefully understand why I use the Escore, why it is something that I keep in rotation in my practice, and why I really believe in the fact that it works. And quick disclosure, I'm a consultant for Subchondral Solutions. We got to get that. Now we got that part out of the way. We can talk a little bit about the product. Some of you may have listened to some of the other lectures. I know that I have, and I've thoroughly enjoyed them. And so I don't want to bore those of you that have tuned in for some of the other lectures. I don't want to bore you too much with some of the foundational aspects of the product. But for those of you that aren't familiar with it, I'm going to take a moment just to give you an idea and some background on the actual implant itself. It is a titanium implant that is HA or hydroxyapatite coated. Of course, you have these ingrowth fenestrations, and the implant itself is threaded. So the implant itself, when you hold it, when you look at it, it may look like it's not titanium, but it's HA coated, and along with the implant itself there are some anchor fixation points that you can use for a dermal allograft, and we'll get to that in a moment. But the implant itself comes in several sizes. First thing I want to make sure I talk about, all of us have been trained and conditioned to treat OCDs for the most part by way of microfracture. And if you're like me, you pretty much were trained that way. You repair these OCDs with a microfracture owl, arthroscopically, and of course, from time to time, you may even repair them open, depending upon the location of the lesion itself. If you take a moment to look at some of the literature that's come out over the last few years, there used to be a general consensus on how you treated these OCDs, how you treated cartilage defects, regardless of the location. And that general consensus held up for quite some time. But there's been emerging research over the last several years that shows that, microfracturing really isn't what we thought it was. A colleague and good friend of mine, Dr. Rushing, spoke about this probably 2 months ago, that there has been a paradigm shift. But the unique thing about it is that paradigm shift has yet to find an endpoint. So while those of us who do these type of cases on a regular basis are starting to see a shift, we're not yet, really sure where it's headed, where the endpoint is going to be. But, using microfracture to repair these, a lot of studies are showing that the end result and the long-term follow-up isn't as favorable as we once thought it was. Me personally, for some of these larger lesions, I would use a talar allograft, where, of course, I would have a talus, shipped in, resect the portion out of it. Aside from being time consuming, it is extremely expensive. You're talking about anywhere from $4,000 to $6,000 or $7,000. But these are just two recent articles within the last few years that show the long-term outcomes of microfracture of the talus. The long-term outcomes really aren't that favorable. And then, of course, comparing the long-term results of microfracture with some of the micronized allogenic cartilage, ECM. And while that may be better or superior to microfracture, it is still proving to be an inferior tool or technique when you look at the long-term results. Jumping back into the Escore itself, it comes in several sizes, so that you have anywhere from a 4 millimeter all the way up to 10 millimeter. Of course, the size is not only dependent upon the location of the lesion, but of course the size. So if you're dealing with a first MTP versus a lesser med or a talar dome, one of the things I really like is that I can use this in any location and any size that I need. Typically, I will tell you, for the first MTP, you're going to be somewhere in the middle, somewhere in that 7 to 9. I believe I've used a couple of 10s on a couple of larger patients. However, for the most part, I tend to use a 7 or 8 millimeter. Let's see if I can bring up this quick video. I guess the little link isn't working. Let's see here. Guess not. In any case,
we tested everything but that.
You know what? We did. Let me
That's all right.
Well, I will bypass that, but I will tell you the instrumentation. One of the things that we know is that in the OR, time is everything. Time is of the essence. When you have a patient in the OR, the goal is to treat the patient, get that patient off the table. And with this particular implant, I can tell you that the learning curve for this implant really is minimal. I will tell you that these cases, first go around, I believe it took 40 minutes, but skin to skin, these cases and the first MTP and lesser MTPs typically take a little under half an hour. And that's from, open to close. The instrumentation is sterile packed. everything that you need comes with it. So of course you have your countersinker, your reamer, and the implant. But I will tell you the learning curve for this, and the fact that you can treat these patients in under half an hour from a practice management standpoint is amazing. And also from the standpoint of getting a patient off the table. Some of the applications and some of the, I've actually done all of these are, arthritis of the first MTP, AVN of your lesser mets, and of course, our classic hallux rigidus and osteochondral defects or lesions of the talus. If you go to the Subchondral website, you'll actually find a few papers, and this is just a snippet of one that spoke about the long-term success of the subchondral bone complex, where we looked at using Escore in these osteochondral defects and some of the more short-term and intermediate-term outcomes. Of course, this image here, this is just showing you arthroscopically, how these lesions can be addressed. One of the things that I will tell you is the first few cases that I did, I was still a bit skeptical until my patients actually started to follow up. When there's nothing that ruins good surgery like follow-up, as they say. But in this case, I will tell you the follow-up is what actually led me to more consistently use the implant and become such a stout supporter. The first case is actually a first MTP and a 73-year-old gentleman who had limited range of motion and crepitus, and he actually had quite high functional demands for someone that is 73. Some of you may wonder why would I be interested in a joint salvage procedure in a 73-year-old? Case in point is he actually is a marathoner. He runs marathons at the age of 73 while I'm half his age, and I get winded after running a mile and a half. But nonetheless, this gentleman came to me, and when you look at these MRIs, one of the things you'll notice, especially on the MRIs in the first met and the talus, is you'll see a lot of edema surrounding these lesions. So the radiologist will tell you that the lesion is 6 millimeters, but if you look at that edema or the edematous changes surrounding those lesions, typically, in my opinion, that bone and that cartilage and subchondral plate has been compromised, and it should be addressed as well. So I think that MR grossly underestimates the true level or the true amount of damage that has been caused. These are some pre-op radiographs. AP view, nothing spectacular, but if you look at the lateral view, of course, you see a very classic dorsal flag sign that we look for when we're looking at patients with these arthritic changes and hallux rigidus. And this is a couple of intraoperative shots. And if you look at the first picture, it is actually kind of hard to tell. That was sort of the funny thing when you actually put this implant in and you use a dermal allograft, it actually blends in quite well with the first met head. And one of the things I will tell you is that I typically use fibrin glue, but one of the things I will also tell you is that the fibrin glue is quite pricey. So one of the things I had to do was I had to go to my hospital and get them to start ordering a smaller size, because I needed a cc or two, and I think we were you opening up a 5 or a 10 cc. This particular patient, this was the first one I actually ever did, and I believe this one was 40 minutes skin to skin. And of course, I was a little unsure how I would actually treat him post-operatively. But what I did was I got him into a walking shoe, and he came for his follow-up about a week later. And I actually started him protected weight bearing within the first week. And by the time he came back the second week and the sutures came out, he was weight bearing as tolerated in a post-op shoe. And so that's something that you won't see in these type of procedures, almost immediate weight bearing in most instances if you're addressing a first MTP or a lesser MTP pathology. A couple of pearls I will share with you. Me personally, I tend to use the dermal allograft in all the cases. You will hear that it is optional. It is something that you don't have to use because of the fenestrations allow for that ingrowth of new cartilage or new hyaline cartilage. But I always use the dermal matrix. I believe in one case I didn't use the dermal matrix, and that was really just to compare the long-term outcomes. I can tell you that while I haven't seen any deleterious effects as a result of not using it, I do feel a lot more comfortable using the dermal matrix. And of course, the fibrin sealant, as I mentioned, get the smallest size you can. Your hospital administrators will thank you because if you use a large one, they might come knocking on your door a little upset when they see how much it costs for a large one. This is the same case, and this is 3 months post-op. So of course you can see the implant itself. Another pearl that I should mention, and this is somewhat of a dealer's choice when you're actually putting these implants in. I think that me personally, I have tinkered around with sitting them sub-flush a little bit more than what the technique guide may tell you. And in some cases, I have intentionally left it a millimeter or so less flush than in other cases when I use a thicker dermal allograft. So one of the other pearls I'll share with you is I think that having a thicker dermal allograft, it actually will somewhat subside once you close up that capsule and the intra-articular pressure begins to increase and that patient begins to ambulate. Between those two things, I think that it actually, for me personally, I sit it maybe a millimeter higher than some others do, simply because when that hydrostatic pressure increases and the patient starts to walk, it actually will have a tendency to sit the implant and the dermal allograft down just a little bit. But this gentleman, 73, within 3 months, he was already back out running a couple of miles a day. He's doing fantastic. He's pain-free, and I can tell you now at 18 months or so, he is still pain-free. I see him probably every 4 or 5 months, and he's doing absolutely amazing. And this is 6 months post-op. And one of the things you'll also notice is the location on this AP view. These lesions aren't always centrally located. If you've done any of these cases before, we all have seen where, based on the position of the great toe, sometimes these lesions will be located somewhat on the outer edge of the surface of the met head. And I can tell you personally that the great thing about Escore, you can actually put these implants, you can put them anywhere on the first metatarsal or any of the lesser mets, regardless of the location of the lesion. The one thing I will caution you is if you're going to be close to the edge of the metatarsal or the bone itself, it's best to use actually downsize a millimeter or so, because you have to always account for those threads. If you don't, once you start tightening the implant and sitting it down, it'll actually those threads purchase another millimeter or so. So you don't want to get too aggressive, because by doing so you can create such a thin wall around the implant that it could compromise the fixation and the stability of the implant itself. So I will tell you my personal post-op protocol for these cases, whether it be first MTP or the lesser MTP. The first couple of days, they're absolutely non-weight bearing. After 48 hours, whether or not I've actually seen the patient for their first post-op visit, I always talk to them and encourage them to be partial weight bearing in a post-op shoe. And if it makes the patient feel more comfortable, I'll even have them use a walker. But the key is the sooner they start moving, the more likely you are to sort of, keep the scar tissue down to a minimum. And of course, this is one of the things that I love that you don't see in these other implants. The patients have to be non-weight bearing for an extended period of time. And by the time you have them ambulating and bearing weight, you're fighting not only the scar tissue, but you're fighting sort of that range of motion that starts to decrease a little bit. And I will tell you, if you have access to getting a patient to PT, me personally being in a rural area, sometimes getting these patients to PT isn't always possible. But in the instances where it is available, I usually will send the patient to rehab, and not necessarily because they need it, but I've always felt that the more aggressive you are on the front end with these patients and getting them up and moving, the better the long-term outcomes they have. And typically by the end of the second week, full weight bearing in a normal shoe, unless it's a diabetic patient or otherwise a vascular path where I'm a little bit concerned about the incision. And in that case, I will typically delay full weight bearing in a normal shoe by an additional week. This is the second case. This is actually a retired military officer, very similar to the first case. One of the biggest differences is, in addition to hallux rigidus, she also had a quite significant bunion deformity with some instability at the first TMT, which of course contributes to the formation of the lesion that she had. And if you look here, you can see the implant itself. Her lesion was actually dead center. And one of the things is she was one of those patients that we all have that goes online, and patients are more educated these days than ever. Patients will go online, they'll do their own research, and her concern was preserving motion. And I think that is really the reason why any of us on this call tonight are interested in the Escore and joint salvage procedures. We want to preserve motion. And in this particular patient, as you can see, she definitely had a pretty significant bunion deformity. And what I did was I actually corrected the bunion, did the lapidus first, and then I actually did put the Escore in and a couple of wild osteotomies. This patient was actually a little bit non-compliant, but needless to say, she's doing fantastic. The first week she came in, she was already trying to full weight bear, which I wasn't too happy with. But it actually showed me that this implant, you can weight bear these patients almost immediately if you choose to. And this is 3 months post-op. And you can probably tell on this implant, the second case, I actually was a bit more aggressive in my positioning and how subflush the implant was. I will tell you, the first time I was probably a little bit gun shy. Didn't want to sit it too far recessed. In this instance, I got a little bit more aggressive, and but in both cases, the patients are doing extremely well. I really want to jump into the third case, though, because after the third case, I think this is where you start to really understand how versatile. To me, the Escore is like a utility player on a baseball team. You keep it in your toolbox because you can use it just about anywhere. We're talking about the foot, the foot and ankle tonight, but you can use this implant all over. This is a 21-year-old female patient that was previously in the military. She was actually discharged after she fell off of a wall during a training exercise and sustained an open pilon fracture. So the first go around, they fixed her fracture. They put her in a cast, and she just had constant pain. So they took her back to the OR a second time, and they used a talar allograft. And tacked it down using a couple of chondral darts. And finally, she began to have more pain. So at 21, she was 2 or 3 surgeries in, and she was referred to me as a last ditch effort. So, anytime you get a referral, from another provider, in this case, it was one of the orthopods at Fort Polk sent this one to me, and so I knew I had one crack at it, and that was it. If we didn't get it right, then she was just going to give up at that point. You can see here, I circled it. You can see even on plain film, which sometimes these are pretty hard to see on plain film, and sometimes you can't even see them, but you can clearly see sizable lesion on the medial shoulder of that talus. And so her MRI showed something that I wasn't expecting. Her MRI showed that she actually had 2 lesions. And so I tried to figure out, how I was going to address this particular case. And what I decided to do was a medial mal takedown. So once I removed the hardware, of course, pre-drilled the medial mal, and once I took the medial mal down, I was actually even more surprised. If you look there on the second picture on the right, that is her talus. That is not where the saw went through. That is actually her talus, and I mean, it was obliterated. The cartilage was obliterated. I actually took a small curette, and my curette just pretty much fell down into the talus 7 or 8 millimeters. I mean, the bone was dead. It was dead bone. And then, of course, the allograft that was used had died. And one of the things I've always believed, but when there were no other options, I used these allografts, these Taylor allografts, but you put dead bone in there and you just end up creating a dead bone sandwich, and nobody wants a dead bone sandwich. So this is the lesion that she had, or 2 lesions. And as I said, I took a curette, and you can almost see the circular allograft that was used. And then adjacent to that is another lesion. So in this instance, I don't recall the exact size. I believe I used a 5 and a 7 or a 5 and an 8. But in this instance, what I thought was going to end up being a pretty typical OCD ended up being an OCD that required the use of 2 implants. And that's something that, of course, I was a bit concerned because this was third shot. These are the type of cases that you stay up at night worrying about how the patient is doing, whether or not you're going to be able to get them back on their feet. And of course, when you're the last person to get these patients, you worry about the litigious nature of the patient. I can tell you this particular patient, she did extremely well. She came in a few days later, and I put these 3 pictures so to show somewhat of a progression. This picture on the far left is immediately post-op. The picture in the middle, that's a couple of weeks afterwards, and the picture on the far right, that is at 3 months. And so, as you can see, she had completely healed, and you can see the 2 implants in there. Like I said, what I thought originally would be 1 implant ended up being 2. And she's actually working. She works as a barista. She works as a barista now on post. And so she stands up, 8-10 hours a day, no pain. I'd still put her in an ankle brace for the first few months just for some added lateral stability. And I guess I should also mention that I had repaired her ATFL simultaneously. So, she actually had a lot of damage in there. Aside from the OCD, repaired the ATFL as well. And I will tell you, I have to tell you up front, these are some, I guess, off-label uses. So these are not necessarily what the implant is indicated for, but what I have personally used them for over the last couple of years. I had a patient where I performed an Achilles repair with an FHL transfer. Unfortunately, the patient dehisced and she had acute osteo. So of course, take her back to the OR, debridement, washout. I take out, all of the implants. And so I actually packed it with antibiotic beads, but I used a magnesium-based bone void filler that had antibiotics in it. And I used the Escore as somewhat of a retaining wall, so to speak, and allowed those porous channels allowed for continuous elution of the antibiotics without allowing the actual bone void filler to seep out and into the soft tissue. And so I have actually used it in this instance. I believe in this instance I used 4 of them. So used a lot of washed out a lot of Aricept, debrided it, and I believe in this one I used 4 in her heel, and she eventually did go on to heal, but I've used it in that manner. This is actually a close-up you can see there. So I used 4 of them, and I've used it when you harvest bone or autograft from the tibia. I've used it to create somewhat of a backfill. So I'll backfill with bone void filler, and sometimes I won't. Sometimes you can just screw it in and leave it there, but it gives you structural stability in those instances. And you can see where I'm actually putting the bone void filler, the antibiotic bone void filler there in the holes from the previous anchor placement. And this one, this is just a little something I threw in. I call this a father's disappointment. And this is my son. He decided that although his dad went to Baylor and I begged him to go, he wanted to go to Texas Tech. And so this is the weekend that Tech played Baylor. And I'm pretty sure he pissed off all the Baylor fans around him because I let him use my box. And him and all of his Tech buddies decided to sit there. But I'm just kidding. I'm not too disappointed, a little bit, but I'll get over it. And in closing, I'll tell you guys that I've used, I think probably used a little more than 15 or so implants, probably somewhere between 15 and 17 implants over the last couple of years. I've had amazing success with it. The patients are doing well. And in this instance, I will tell you that microfracture, as we stated earlier, microfracture is not the answer. We thought it was, but microfracturing is not the answer. And the other available options to us and alternatives really weren't sufficient as well. They weren't sufficient either, but it's what we had at the time. But I can tell you that the long-term outcomes I've had with my patients have been stellar. And I do believe that this implant is one that will continue to be one that serves myself and my patients in a way that allows me to get my patients back on their feet. And with that, I will be ready to field any questions or comments from you guys. So I'll open it back up to Matt. I'll let you kind of take from here. Let me know if there's any questions in queue.
Yes, sir. Yes, sir. I got a few, and awesome. Thanks for keeping it short and sweet. I love the last 2 cases. I got a couple. I got a couple of good laughs. Text dead bone sandwich. Loving that. And I wanted to say the last one that you talked about, with the Achilles and being off label. What was interesting that what you said about it though is the way you used it in compressing the bone and how you use it to, you say off label while at the same time it's still on label, because that's kind of where Escore comes from, is compressing subchondral bone, and I understand what you meant by that, but some of the doctors that don't know a whole lot about it yet just see this as an implant for OCD lesions, and not realizing kind of where it all originated from, which is exactly what you said. So I love it. Let's see. Yeah. So we have it. I think you touched on it a little bit. Rehab protocol for first MPJ versus Taylor Dome. Lesser, probably less worrisome. I know you kind of talked about that. If you want to touch on that, just on rehab.
Of course, no, I'll definitely touch on that. So I think the first thing you have to consider is the application and the approach.
Yeah.
That when you repair these talar OCDs. So for myself, I will do a medial mal takedown most of the time. If I do a medial mal takedown, they're offloading for 6 to 8 weeks, until there's radiographic evidence, there's significant cortical bridging. They're non-weight bearing for, I treat it like a fracture, right? So 6 to 8 weeks non-weight bearing. And once that period is over with, I get them into a cam boot for a couple of weeks and start aggressive, formal outpatient PT. However, for most of my patients, if they qualify for home health, I will actually have PT come into the home and work with them from day one. So from day one, I'll have in-home PT for these patients. If of course, it's covered by insurance, I'll set them up that way. Not too aggressive at first, but definitely you want them moving from day one. And that's the beauty of this implant, is you can have them moving day one, not necessarily bearing weight. When you're talking about these medial mal takedowns. Now, if you're doing like a posterior medial approach where the patient is prone and you're dorsiflexing the foot in order to access that talar lesion, you can actually start walking them pretty quick within a few days. However, if it's the first MTP or any of the MTPs, typically the first 2 days, I just tell them keep their foot up, take it easy. And usually within the first week, I see them. And as long as there are no wound complications, no issues there, I actually have them start active range of motion at home. And by the end of the second week, when the sutures come out, I leave them in a post-op shoe, and I have them weight bearing as tolerated for another week. And then from there, they go into a regular shoe. Of course, you have to always consider the individual patient. So if there's any type of, concerns that you have for delayed healing, or, because of diabetes or other metabolic diseases, if they're a smoker, vasculopath, always take those things into consideration. And of course, preoperatively, you should always consider those things and make sure that they're vascularly optimized. But notwithstanding anything like that, I'm actually very aggressive. I've become more aggressive as I do more cases. I've actually become increasingly aggressive with these patients. And what I have found is that the more aggressive I am with them post-operatively, the quicker they get to that pain-free, that point where they're pain-free. The less aggressive I am, they still get to that point where they're pain-free, but it takes a little bit longer. So I will tell you, use your own discretion, but being aggressive has actually worked to my advantage in these cases.
Yep. And in between these questions, I'm going to touch on some of that. What you mentioned about using the dermal graft and being 3 millimeters and being a little more aggressive and, being just below the tide mark. I've done, with you and other surgeons, quite a few cases, and I'm seeing the same thing, especially with getting more aggressive with post-op and using the dermal graft and those type of things. I think, we're 3 years into it, but, you're always learning more. And I think, going a little subchondral or even sub of the condyle with having the graft on there, and the patients being so aggressive, and the physicians like yourself saying, being aggressive on rehab, that seems to be all working better. So, which brings me to the next question. Given you've had a couple of comparisons with patients where you've utilized a dermal graft with Escore as opposed to standalone, have you seen specific differences with your patients post-op observation due to those comparisons?
So I can tell you.
So graft or no graft, yeah.
Yeah, so I can tell you that the dermal, with the dermal allograft, just being completely candid, I think I have a bit more confidence in being aggressive with them when I use a dermal allograft. So I'm a bit more aggressive, a bit more confident in being aggressive, simply because I know that cushion is there. I know that that extra layer or buffer is there in the joint. When I haven't used the dermal allograft, I have not been quite as aggressive. But all that being said, post-operatively, looking at the timeline, comparing apples to apples, I can tell you that I have not seen a significant difference in the outcomes clinically. Clinically, I've not seen a significant difference because remember, when you prep the bone for this particular implant, you're creating a almost looks like a dowel. When you stare down the bone, it almost looks like a dowel. You create a trough, and so what's happening is you're stimulating after that an immediate inflammatory response has subsided. And that sort of that cytokine rush, you're stimulating the regrowth and ingrowth of that hyaline cartilage through those fenestrations on the end cap. And so, with that being said, you're going to have a buffer there. You're going to have that hyaline cartilage there. However, you don't have the immediate buffer that you do with the dermal allograft. And so I just tend not to be as aggressive when I don't use it. But as when we talk about outcomes, I have not seen a difference in the outcomes.
Good. A good question, kind of a two-part question, Mr. Brandon, from Mr. Brandon on case number 3, which was, this is good. How much of the patient's talar shoulder was compromised? So it was kind of a 3-part. So did the MRI show the subchondral bone deficiencies to give you an idea of whether or not you could use the Escore, or was that an intraoperative decision? How did you address the concern about the Escore having enough bone purchase to hold and allow for remodeling and healing, given the degree of AVN involved? It was just a messed up ankle. So
right. So here's the thing. As you guys know, when I read these MRIs, I do 2 things. One, I look at the MRI, the images myself before I even look at the read. I don't like to look at the read because then it guides subconsciously. It guides how we all view the images. To be honest with you, whether or not you think it does, it does. So I tend to look at the images myself first before I look at the read. And on the actual image, you see a lot of edema, but because these lesions were so close together, it looked as if it was just one large defect almost. So you couldn't really discern the individual lesions. However, the posterior lesion is what they're probably referring to. That posterior lesion was actually quite close to the shoulder, and that was a concern of mine because, as I mentioned this earlier in my presentation, when you sit that close to the shoulder or the edge of the bone, you have this innate concern for having enough stability and having enough bone there to support the implant. And so that was an initial concern of mine. And I probably even undersized the implant a millimeter just for that very reason. And so, yeah, I'll be honest, I was definitely had a pucker moment there when I looked at the size of the lesions and how much bone, the amount of bone I had left to work with. So it was an intraoperative decision to use 2 Escores. Now, I did that particular day, I did have a talar allograft on standby. And so that was an intraoperative decision. But there was definitely a concern because that lesion only sat 2 millimeters off the shoulder. And when we talked about this earlier, structural stability, right? I didn't want to compromise structural stability. And so what I intentionally undersized the implant. And what I found was the defect, not only diameter wise, but depth wise, the defect was quite large or quite deep. But that was an intraoperative decision. I had both options available to me, and I made a decision at that time, based on the location and the size. It would have been quite tough to address that using an allograft. And to be honest with you, I have all but abandoned, allografts in my practice just for the simple reason, what I said earlier, dead bone sandwich. It just really has no place in my practice. I really don't think it has any place in these type of cases anymore. Now that we have products such as Escore available to us.
Awesome. Another one just come in. When using a dermal allograft, the goal is to have the graft survive. So would one have to slowly return to weight bearing to allow phase 1 and 2 of ingrowth into the graft? Would early weight bearing and range of motion destroy these vascular channels? And experience, how are CTs with the core after? Do they cause significant scatter?
Okay, so what was the first part? What was that first part?
Yeah, when using dermal allograft, the goal is for the graft to survive. So would one have to slowly return to weight bearing? Okay, so yeah, to allow phase 1 or 2 of the ingrowth of the graft, would early weight bearing and range of motion destroy vascular channels?
So I will tell you, now
Good question.
Yeah, great question. So, we could probably kind of go back and forth, on a microscopic level or microvascular level, whether or not how we feel about that first question. I will tell you, in my experience, as I mentioned, I use the fibrin glue. So when I use the dermal allograft, of course, the goal is for this, is for it to survive. By using the fibrin glue, I create almost a seal around the actual dermal allograft and the implant. So in essence, I'm insulating the dermal allograft to protect it from any type of external forces, whether it be shearing forces. But I use that fibrin glue to create that seal to channel off and to protect that dermal allograft to allow it to serve its purpose. And as far as vascular channel ingrowth, well, that is one of the reasons why this implant is hollow, and why you have this sort of dowel or this this recess, and that in and of itself is to allow from that medullary canal for those small micro vascular level to allow for the ingrowth. And so I can tell you, if looking at my post-operative films, I have not seen any collapse. And of course, that's one of the first things I look for. I look for the implant. Has it collapsed? Is there any subsidence in the implant itself relative to the initial placement? And so one of the things that I have the rad tech in the office do is I'll make sure that when we take an AP shot, for instance, or a lateral, that we try to make sure they're good APs and they're good laterals, and I'll actually look at the distance sub flush to see if it changes from one visit to the next. And I have not had any issues with that. As far as CT and creating scatter, like any other type of metallic implant, of course, you're going to get some scatter. It is a metallic implant, even though it is HA coated. So yes, you will get some scatter, but I have not had any issues with subsidence as a result of creating additional avascular necrosis by way of choking off vessels or preventing that vascular ingrowth.
Sounds good. Let's see. One more, I think, here for first MPJs. Do you ever shorten the first ray? If so, what or how? What type? Proximal or versus distal?
Do I shorten the first ray when I use this implant?
Yes, sir.
So I actually have shortened the first ray a little bit in these cases. So I'll go back to this one, for instance. So in this case, I knew I was going to shorten the first ray just by virtue of the fact that I did a lapidus, right?
Yep.
I took cartilage off the opposing joint surfaces at the first TMT. And of course, the way you counteract that is, in this particular patient, I did a while of the second and third. I'm not one that necessarily subscribes to the belief that, shortening of the first ray within reason is detrimental to the patient. I think, shortening the first ray, as long as your joint prep is appropriate but not overly aggressive, the shortening that you get in the first ray in these type of cases where there's a concomitant, first TMT fusion and Escore, I don't believe that the shortening of the first ray is substantial enough to concern yourself with, overloading the lesser mets or suffering from lesser metatarsalgia. However, the whiles, and this was early on in my usage of the implant. So as a CYA and just trying to do things, by way of textbook, I did shorten the second and the third met to sort of accommodate for the fact that I did shorten the first ray.
Awesome. Right. Believe that was the last question. Unless I get anything last second, but we are coming up on the hour, so perfect. Great presentation.
Thanks for having me.
Oh yeah, no, thank you, Dr. Benson. Thank you everybody for joining tonight. We were planning on having a couple more here towards the end of the year, which is, we all know, is going to be very tough to squeeze in. But yes, sir, Dr. Benson, we really appreciate it. And once again, thank you for everyone that could make it tonight. If you have any questions, concerns, most of you have my email or numbers if you want to talk to Dr. Benson.
Just a sidebar,
Yes,
if you guys, anyone that's on this lecture, I guess tonight, or that listens to it, obviously you can reach out to Matt with any questions. If you guys want to reach out to me, you can find me on LinkedIn, and by all means, please reach out to me. I'm more than happy to share additional cases or any pearls with anyone. You can find me on LinkedIn, and I'd be more than happy to talk a little shop with you.
Awesome. All right, guys, everybody have a great evening. Dr. Benson, thank you again. And good night. Go Astros. Oh, shit. Thanks again, guys. You guys
take care, man.
All right, bye.
Bye, everybody.